Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. Dr. Sonia Leziy has been recognized as one of the top clinicians in continuing education by Dentistry Today for the past several years. Sonia has lectured internationally on the subject of implants and advanced aesthetics, periodontal, and plastic surgery. She is the Executive Vice President for Clinical Affairs with the Seattle Study Club and co-director of the Vancouver Implant, Periodontic, and Prosthodontic Study Club. She is actively involved in clinical research with narrow diameter implants, and in this presentation discusses methods for improving implant outcomes.
Hi everybody, my name is Sonia Leziy, and I have the honor of sharing a little pearl with you about what might make my job a little bit easier or more accurate and do better treatment outcomes for my patients. So there's all sorts of technological things that I could show you, but what I thought I'd do is the little tips and tricks that I actually think about every day in my practice, not building in the $30,000, $40,000, $50,000 machine that you need to buy to be able to do this. I thought I wanted to give you something that was fairly simple. So I looked at this and I called it looking at surgical adjuncts, the little tricks that I use to improve my treatment accuracy. And the first thing I look at is, as you know, a lot of you probably know, I spent a lot of time in implant dentistry. And I look at the keys to controlling tissue architecture, and it all starts from the moment of tooth extraction. So we extract teeth, and we understand that the moment we pull a tooth out, you're going to see some soft tissue changes instantly. We watch the tissues slump into the extraction area. And when I think about putting an implant in there, historically, what I would do is actually place a standard healing abutment. And I realized when I look at this photo that, well, that healing abutment, in fact, doesn't do anything to control the tissue architecture. So you see that it is non-supportive. And you know, I find that a lot of my own education certainly comes from reading, but a lot of it comes from talking to friends and colleagues at national symposia and other meetings. And we started talking about how do you co-support tissues other than the cases where we might put a provisional restoration in place. Obviously, provisionals beautifully scaffold tissue architecture, but you have to have the keys for that to work, which means that you have to have a very stable implant, a cooperative patient, a favorable occlusion, and not every case is like that. So I wanted to look at, well, what can I do in the cases where I cannot provisionalize instantly to take charge over tissue architecture? And a couple years ago, before this particular article came out, I saw it in an EPUB, which is ahead of print, and it talked about, probably back in 2014, the very important role that healing abutments actually plays in guiding tissue architecture. So, we put a little stock healing abutment on. It's like a little cylinder, and it does nothing to support tissue architecture. And this study actually looked at the very valuable role of some type of anatomic healing abutments to co-support the tissue architecture. So I started playing with that, and certainly talking to other colleagues who were looking at this as well. It encouraged me to take a look at it more seriously. So this illustration really shows you the idea behind getting away from those stock components and really fabricating customized components chairside to co-develop the tissue architecture. So what I've done is I took a temporary titanium abutment and I customized it in the mouth on the implant to scaffold the tissue architecture using a composite material. And you can see that it lends support to the marginal tissue architecture. And all I've done here, because it was a case where I did not want to provisionalize, was to put a splinted restoration in place. So very, very simple little tool. So I'm going to take a look at a couple of cases to help you understand how I go about doing this. So where do I fabricate customized healing abutments? It is in 100% of my cases where I'm doing immediate implant placement and where I feel that I cannot do immediate implant restoration. So that would be the optimal scenario. You certainly can do this in cases where you're dealing with a healed ridge, but it's perhaps a little bit more work and effort. So the key is I remove a tooth, I place an implant, and my goal in showing you this clinical shot is that you have to think about very carefully the size of your implants, because we really want to ensure that we have favorable bone volume on the facial aspect of our implant for long-term tissue success. And based on what we know in our literature today, there are a few critical elements. That is, you need, well, I'd say the minimum is 2 millimeters of bone thickness on the facial, but realistically we need probably like 4 millimeters to make the treatment outcome predictable long-term. I tend to submerge my implants a hair. That means, half a millimeter or a millimeter to put them in a more protected environment. And then I'm going to deal with any of those bone defects and using membranes if necessary. But some kind of bone grafting product's going to go in there. Then I fabricate a custom healing abutment in the mouth, which means I'm going to put on a temporary titanium abutment, and I'm going to flow composite around it, quickly set it, keep flowing it, quickly set it until it captures the form of the marginal tissues. Then I take it out of the mouth and I finish it benchtop, because there are going to be voids or discrepancies. So you can see as we move from left to right that I've got a more normalized anatomy as I've done the extraoral finishing, and then I basically smooth it out, clean it, steam clean it, and pop it back in the mouth. What I'm also doing today, and although I'm not going to discuss this in any length today, is because I'm working with an optical scanner and I'm taking very clear scans of my patients before treatment, my laboratories actually can prefabricate these for me when I'm truly doing guided surgery. And that takes a lot of work out of my hands in the surgical setting. It avoids, another 15, 20 minutes of the time that I need to dedicate towards fabricating these types of customized healing abutments. So if we go back to this case, I've done my bone repair. I've fabricated my provisional guided healing abutment, and you can see it in position here. And you'll notice that it's a little bit short of the facial margin. That was done intentionally because my patient happened to have recession, so I wanted to allow the tissue to creep back into that area. Some of the tips and tricks that are important is that when I place these customized healing abutments, for that matter, when I place any healing abutment, I always torque them in place, and I torque to a minimum of 20 Newton centimeters, because if you torque them, you're going to have a clean hermetic seal, whereas we finger tighten, it is not a clean seal, and therefore bacterial ingress can potentially increase the inflammation in the area. So definitely little simple trick. And then I'm going to seal that area with the little screw access with a composite or something more, actually more clearly using something like a ferment material. And then we have a nice clean environment for the uneventful healing that we anticipate we'll see in the next 10 to 12 weeks. The keys were that, I'll tell you, when I go back and I look at these radiographically, the bone levels are actually spectacular on all of them. So I'd encourage you to look at it from the perspective that it molds your tissue architecture, but it's actually creating this beautiful marginal tissue seal, which in fact is very protective to underlying bone. So I've showed you an anterior case, but you know what? I do this everywhere in the mouth. So I'll show you a posterior region. This is a molar area. And I was inspired in one of my conversations with an oral surgeon that I know, a good friend of mine at one of the meetings, who said, Sonia, you got to think out of the box, and you have to start looking at more posterior areas, because there is some logic to the immediacy of placement where you can consider it in posterior areas, especially if we're considering looking at customized healing abutments as well. But my problem I always had with molar areas is I might section and cut roots out very carefully, use all sorts of tools to get them out without damaging bone, but then you have a whole bunch of holes and you're trying to prep your osteotomy, and I tend to fall into those holes. So I looked at this case and it inspired me to think, all right, I have this fractured tooth and I have this beautiful little table or base that I can look at as a help to get me starting my osteotomy. So what I do is I'll cut teeth down right to bone. I'm going to section them. I'll loosen them a little bit, and somebody gave me a trick the other day, said, well, Sonia, you could actually technically take it out and then put the roots back in. And then I'll literally prep my osteotomy through the roots and bone, and so I'm not skating and falling all over the place. I'm not falling here into the mesial or distal socket. So very simple little tool to improve the accuracy of the osteotomy. So I'm going through my drilling steps, and you can see here I have a direction indicator in those roots, and I'm basically checking and verifying, yes, I am happy, in fact, with the position of the initial drilling, and I go through each step. Once I've actually finished all my drilling, I pop the root out. And here I'm simply showing you the root is actually shaped by the osteotomy created by that drill step. And then once the root is out, the osteotomy is already finished, in goes my implant. Then I'm going to bone graft around my implant because we have a very large residual horizontal defect, typically, especially in a molar region. So there's all sorts of things we can graft with, and I'll admit I use a lot of xenografts, which are cow bone products. But today, increasingly, I'm starting to look at using other materials. And so some of the things that I might use would be, certainly I use human bone products. And historically, I was always using mineralized human bone products. But today, I'm looking at how literature is shaping what I'm doing. And if we look at this particular work, this is a study out of San Antonio, it tells us that when we're looking at using human bone products, perhaps the combination of mineralized and demineralized bone would be preferential in view of the fact that we see a greater degree of vital bone development over the course of the healing period. So I've gone to this mix of this 70-30 allograft mineralized / demineralized mix. But I'm also mixing in with that perhaps little adjuncts that might help how bone actually heals. So what I'm doing is I'm using PRF, which is platelet-rich fibrin, and here I'm showing you creation of plugs, or I can make sheets. And I'm basically taking those plugs or sheets, cutting them up, mixing them in with my bone to throw in growth factors from the patient, just in case it may actually help me improve bone quality. Because in fact, some of our literature tells us that we can improve quality, for instance, from a density 4 to a density 3. So if it helps, I'm going to do it. It's a very simple little step. So that bone would be applied into the residual defect around the implant. So what did I do, let's say 3 years ago? I would have placed a standard stock healing abutment on the implant, and what do you expect to see? Is tissue slumps back, moves towards that healing abutment. So we lose all that beautiful anatomy that we had on day of surgery. So what I do today instead is I'm going to fabricate my custom healing abutment, just like I showed you in that interior case, and I do this in molar regions as well. So think about it. We surgically can totally set our restoring dentists up for success. You take this off, and there's a fabulous tissue framework left for them. You talk about going easily to impression now. Take an impression of that, you transfer that to the technician. I guarantee you, you set an environment where you're giving them this lovely tissue architecture that actually looks like a tooth is supposed to come out of there, not like the little mushrooms that we create with standard stock healing abutments. So when you look at these two examples, really beautiful tissue anatomy, but what I want you to look at is on your slide on the left, you see some particles of bone. At the time when I was doing this, I was actually using a cow bone product, and I was actually overfilling the sockets. And I think there are some negatives to doing that. Some people contend that it may support the marginal tissue architecture. My feeling is the problem is that, you know what, those little particles want to exfoliate over time. And it's much more clearly seen in this case where you see large amounts of exfoliating particles. So I would say if you're going to bone graft, and I do think you should, there are many materials you can use, but you really want to go flush with the crest of bone, not overfill, in order to avoid this kind of problem. So what I tried to inspire you to think about was immediacy of implants in many areas, thinking about maybe how you're managing bone, absolutely how you manage your soft tissue. And I think these customized healing abutments have become my key to success. And in fact, I actually think my tissues sometimes are more beautiful doing this than even when I use a provisional restoration, maybe because we're in a completely non-loaded environment. Fabulous tissue architecture, amazing bone outcomes. And my goal is surgically to give my restoring dentists the best treatment possible and get them into that path for success. So that was my little tip or trick to help you improve the, in a simple way, what you can render, what you can offer to your patients. And it's been a pleasure to give you a little pearls of wisdom. Thank you.